Good morning, everyone. Good morning. We're going to go ahead and get started here with Grand Rounds. We have Dr. Carter here, and I'm going to have Dr. Estelle Williams give our introduction.
Good morning. Good morning. I hope everyone on Zoom can see me okay. Thank you all who are able to make it here in person. And for those of you who are on your way commuting, drive safe. It's treacherous out there. And don't take light rail coming from the north. There's a power outage. Don't ask me how I know. It is with distinct honor that I am able to introduce our diversity grand round speaker for this year, 2025. Just to give some context, our department has been and continues to be a steward around what it means to bring inclusive voices and elevate the voices of all individuals throughout our diverse community within the surgical field. With that, the Diversity Grand Rounds has been established going on 7 years now that brings in faculty members to highlight not just topics around what it means to continue to enrich our wonderful field of surgery with those unique voices, but also that we represent the entire spectrum of academia and academic excellence. And with that, we bring with the Diversity Grand Rounds an invited lecturer to help share that academic excellence or a topic that helps enhance our surgical community. It is my distinct honor to introduce one of our prior graduates, Dr. Damien Carter. I have a very personal connection to Dr. Carter as he was my chief resident and my fellow when he continued on his Burn Fellowship here at the University of Washington. And we also share the same hometown of Oakland, California. So we have a lot of cross connections. Dr. Carter earned his medical degree from the University of Illinois, Chicago, University of Illinois College of Medicine in Chicago. He completed his residency in general surgery here at the University of Washington, where he also completed an NIH NRSA T32 research fellowship in trauma and burns immunology. He subsequently completed a burn and surgical critical care fellowship at Harborview Medical Center in Seattle, and currently specializes in burn care, including acute management, critical care, and burn reconstructive procedures. He also serves as the medical director of the Burn and Soft Tissue Service at Maine Medical Center. The Maine Medical Center burn program currently sees approximately 175 inpatient burn admissions and nearly 600 outpatient visits yearly. The BST service is the only provider of comprehensive burn care to burn injured patients in the state of Maine and northern New Hampshire, with a catchment area of roughly 1.5 million people. It also cares for complex wound and cutaneous disease that requires surgical management. In addition to his clinical responsibilities with the BST service, Dr. Carter is an attending on the trauma and emergency general surgery services as well. He has a strong research interest in burn resuscitation and modulation of the inflammatory response to injury. He's received internal and external grant funding to pursue his basic and translational research interests. We are excited to bring his lecture here today, entitled Mitochondrial Dysfunction and the Immune Response After Severe Injury, a Novel Therapeutic Target, and a highlight to the academic excellence that we have of both our graduates and across the surgical specialty, regardless of what you represent phenotypically, despite what our current administration will have us believe. So we appreciate what you bring to this Grand Rounds today to the surgical community overall, and as a proud graduate at the University of Washington. Let's all give Dr. Carter a welcome.
Hey, thanks for having me. It's good to be back. I remember this room, not the remodel. Obviously, it's much better than it was before, but it's good to be back here. Yeah, it looks good. Looks really good. Yeah, so it's great to be back. I got to catch up with a lot of people, and yeah, a lot of good memories here, and taught me everything or most of the things I know, at least about surgery. And yeah, it's spent a good chunk of my life here, and yeah, it prepared me for. You can, I guess, feel confident that you'll be prepared when you come out of this program for whatever journey you go on. So this talk I'm gonna give, I try to make it a little bit more interesting than you can get a little bit too basic sciencey or I'm going to try to like talk it as like the journey of how we kind of came to some of the conclusions and how we got there. Like it, started with the sort of idea and we just went on this like other tangent um, to where we really study mitochondrial dysfunction after injury in sort of a holistic way and how we can modulate that. I don't have any relevant disclosures. Always looking for them though. So just overall, so burns is about there's about 500,000 burns or so that make it to some sort of healthcare. So and emergency department and outpatient visits, so on and so forth. About 3/4 of that ends up being managed at a burn center. The rest are managed at the other 4,500 acute care hospitals as far as admissions. There's been about 4,000 inpatient deaths for a couple decades now. So we don't have a ton of death, which is sort of pushes the paradigm out to recovery, functional recovery, longer term outcomes. And so that's kind of a big focus. But we still do have deaths, and a lot of the early deaths are or a lot of the death and after burn injury is related to inhalation injury, but we also have some resuscitation failures. And so it's still an important area to look at, to evaluate. And so that's kind of, where my, the journey for me starts on this. And so I like this, I made this schematic a long time ago, but it just kind of helps me organize in my head, like how this, the immune response after injury works and kind of the areas where historically we've tried to modulate this or affect this and some of the current approaches. So you have an injury, and it doesn't have to be a burn. It could be a MVC with pelvic fractures and other trauma. But you have a significant injury. There's a big early inflammatory release of these damage molecules. We call them just collectively damage associated molecular patterns. Importantly, a lot of the most potent ones are actually remnants of mitochondria, and that ends up being a very important aspect of this work. But these early signals potentiate a cytokine-mediated response, inflammation, all kind of classic things you're used to hearing about, third spacing of fluid, and so on and so forth. This is sort of the process for any inflammation. So you have a pro-inflammatory response, and you have an anti-inflammatory response that's initiated at the same time. And generally, that comes back into a homeostasis of inflammation, I'll call it that, at about 7 days. It's pretty if it works. When it doesn't work, you get this sort of dysregulated immune response. And it could be a mix. It could be, more of an anti-inflammatory phenotype or a pro-inflammatory phenotype. But we think a lot of that has to do with with genetics, right? And a good way the way I think about it is evolutionarily we're set up for the saber-toothed tiger to rip our leg off, right? Leg comes off, the vessels thrombose and retract, right? We're sort of set up for that. Now, I don't know how we deal with the infection and the stump and whatnot, but we're sort of set up for that kind of trauma. But we're not set up for large TBSA burns or really significant injuries. But the body is just overreacts essentially, right? Now, since there's no pressure from an evolutionary standpoint on that, because you can have kids and pass on your genes before you get hit by by a tree or something like that. There's a lot of variability in that, and so that's where I think you get the variability in response. So that's that genetic effect, or genomics. And then this sort of like dysfunction, this is sort of those patients that you see that kind of fester, have like multiple infections, and just are in ICU for 60 days. That kind of group, and it's like generally referred to as a post-inflammatory catabolic syndrome. And so there's a lot of research into how we could predict that. So predict dysfunction. So if you can predict it early on in the injury, maybe you can use some of these anti-inflammatory drugs and things like that acutely to affect the outcome. Because most patients are gonna do okay. So when we use these, we try to get involved in modulating the immune response. We're probably disrupting a lot. We end up disrupting a lot of normal responses to the injury, right? And so that's where we've gotten all these mixed results as far as anti-TNF and various immune modulation techniques, because that's probably just it is a complex system that we don't really understand. We did incidentally invent a lot of really good autoimmune disease drugs like Remicade, and sort of like the child of that kind of line of research. But a lot of most folks have moved away from that. And so, and then on these early failures of resuscitation, none of all of that stuff is too far downstream to really be a valuable target, right? So, DAMPs kind of, or if there's a way to sort of disrupt or take the wheels off the bus, if you will, before it gets running, before it gets down the hill, that's probably going to be our target. And that's kind of how I've looked at it. To bring it to burns, you have your burn injury, and this is kind of where how our management kind of complicates this. You have the early damp response, the same idea. You get this endotheliopathy of trauma, everything's sort of vasoplegia, hypotension, all of those leakage in the vessels, the edema, pulmonary complications that come from that, right? Which is where most of the mortality, especially when you compound that with like inhalation injury. And then what we do is doesn't make any sense, right? So we give crystalline, which we know does not help that. Actually makes that worse, the endotheliopathy. And it definitely makes that worse, right? And so what do we, how could we affect this so that, either we can use a lot less of this and have less damage, or use something else, but sort of stop this process. And that's kind of where I started. And when I left here, actually right around the time, there was a lot of this, like a super hot topic was damage, damps. And the first article that kind of put it on the scene was this Nature article by C.J. Hauser, Beth Israel, and just really demonstrated that these mitochondrial damps were like the initiating event to this process. And a bunch of, then there was a plethora of papers that came out on this over the years, a lot of study in this area. And there was, I think it was particularly this this last paper from University of South Alabama. It caught my interest because the level of plasma mitochondrial DNA, which is one of these damps, was essentially at super high levels. It was essentially associated with 100% death. So if you got that level, the patients died in this study. It was a small study, but it didn't make sense to me anyway. That it's like, where does all this mitochondrial DNA come from? It can't just be from the injured, the broken pelvis, or just the burn injury. Like, there's some potentiating thing. And so so early on, well, first I get to Maine Medical Center. I got to figure out where the bathrooms are, and where the trauma bay is and not get lost, we're able to get there. But once I kind of settled in, I was thinking, wanted to get back into this, and just as a segue, I did research in the T32 with Dr. Arbabi here, and we studied a topical inhibitor of inflammation. So basically, you put it on the burn wound. The topical P38 MAP kinase inhibitor worked really well, and the beauty of that was that it was topical. It was a local effect. It didn't have a systemic effect, because obviously, if you give a P38 MAP kinase inhibitor to the systemic, you'll just shut everything down. That's not good either, right? So anyhow, it worked really well in our studies. And then, obviously you go back into, come out of T32, you go back into residency, and, all of that kind of takes a back seat. So it's like, well, man, I would like to, sort of get back on the horse, so to speak. So my thought was like, okay, like, maybe let's see how this does with damp suppression. It's like, can you topically apply this with like block damp release? And so I started this collaborative. There's at Maine Medical Center, there's well, back then it was the Maine Medical Center Research Institute. It was actually really, really well resourced facility, about like 8 miles from the hospital. So not like, not down the hall, but anyhow, I started to make connections there. Got, started talking to this PhD scientist there, Igor Prodovsky. And we've been at this for like 7 years now. So the collaborations are like the only way you can really do this as a busy surgeon. But anyhow, I was kind of just throwing these ideas around, and this is probably the best part of the collaboration. He thought of like, well, why don't we just look at this phenomena without inflammation, right? And see what happens if you expose a white cell to a damp, in this case, mitochondrial DNA. So this study, this kind of like started our whole like core, like down this whole pathway. But this study was on HL60, which are HL60. Still up here. I don't know. Okay. So these HL60 stem cell, or not stem cells, that's not right. Promyelocyte cell line. You can differentiate them. They're white cells that can be differentiated into granulocytes, or just be left in their undifferentiated form. So anyhow, in media, we just exposed, in the media, we exposed them to mitochondrial DNA from mice. These are HUVEC cells, so human umbilical vein epithelial cell. Expose them, it's an MD, that's just exposure to mitochondrial DNA. And we look for the presence of human DNA, which has human mitochondrial DNA. And by PCR, we had a huge jump. So like this release of mitochondrial DNA from the cells with no inflammation, right? Just exposure to a damp, right? And when we put them in media with P38 MAP kinase inhibitor, they didn't release it, right? And interestingly enough, this wasn't even really like this. One of my partners was like looking at a TXA for anti-inflammatory effects in kind of like a different context. But we're like, why not just throw it in, right? See what happens, right? So we put TXA in there, and we had basically the same effect as a P38 MAP kinase inhibitor. It inhibited this release. Didn't seem to have a huge synergistic effect, like it go way down with that. And so like, okay, like maybe we're onto something here. And then we also, um, neutrophils can do this thing where they form a net, sort of like a big phototosis, and they'll sort of swoop up bacteria and then eat by so we demonstrated there wasn't like release any like mitosis, because that would have been a reason why like maybe it caused mitosis. That's why you're getting it's just and TXA and P38 kinase inhibitor maybe are just mitosis blockers or something, but we didn't have mitosis even in the ones that were just exposed to mitochondria. So we also looked at platelets, which are extremely hard to work with, but didn't have the same effect. Like it didn't cause a release when platelets were exposed to mitochondrial DNA from the mouse. They didn't release human DNA, or human mitochondria. So we definitely we felt pretty confident that there was a mechanism where this was just being attention. So the inflammation might have this or not. The inflammation from the injury would activate these white cells. They would spit their mitochondria somehow. And so then we got really interested in the TXA part of this, because it was like, like that's something you can apply to anything. Like you don't have to with the topical inhibitor. It really just only applies to burns, but with TXA maybe we could apply it to any trauma or any injury. And so TXA is probably pretty familiar to everybody. It's this antifibrinolytic lysine analog. It blocks the binding of or conversion of plasminogen to plasmin by TPA. That's most well known. But it's always actually been, or for a long time, been known to have some anti-inflammatory effects, like suppression of neutrophilia. So that, not extensively studied, but for the anti-inflammatory effects, but they were definitely known before. But very well studied, obviously, for its plasminogen effects. Incidentally, this just a side note, interesting side note. TXA was actually invented by a Japanese woman, female scientist, in 1960s, like 63, and they just basically buried it until 2009 because she was a woman. Like, really no other explanation, but it was known, and she presented on it for like hemorrhage control and obstetrics actually. But anyhow, that's just an interesting side note. Just buried for like 50 years or something like that. And the one that was used preferentially is 62 times less effective or potent as epsilon aminocaproic acid. So we kind of continue on this line, and again, still on the cell level. We looked at the Huvik cells to see how well they clump, essentially. So this is kind of a measure of the endotheliopathy, or whether this TXA had effect on endotheliopathy. And we showed that the presence of TXA kept their, to sustain the tight junctions between these endothelial cells. So we're like, this really does have like a pretty potent effect. And so then you got to try to get some money to actually like study this stuff. So, and I was, fortunate enough to get funded by the AAST. The plan here was to look at P30 MAP kinase inhibitor and TXA, two different experimental groups on burns. So basically at sham, you had the burn injury, about 40% skull burn. And then in one treatment group got topical P30 MAP kinase inhibitor, and then the other one got TXA. And we wanted to look at mitochondrial DNA release systemically. So this was all immediate application after. So, and what we showed was that P38 MAP kinase inhibitor worked really well topically, but also TXA worked about as well. And it didn't seem like to be any really big added effect when you put them together. but clearly it was a potent, at least for this damp, or very important damp, a potent inhibitor of it. And so, we're definitely feeling like we're like on to something interesting. And so this is just looking at lung inflammation. Again, we had less inflammatory cells in the lungs with the topical inhibitor, but also with TXA had a very similar effect. So, and we published this in like 2019. And then this was like a little bit of a side. We were kind of curious about its effects on mitochondrial respiration, like what was TXA doing? Like why did it have this effect on like suppression? And we did some. This is the seahorse analyzer data. We did the isolated rat burns like later, but I'm just included here like a few years later. I'll talk more about that. But on HUVEC cells, we were able to demonstrate that TXA increased respiratory capacity in mitochondria, isolated mitochondria. So it has some sort of like trophic mitochondrial protective effect. And it's really lined up with that original data. Like this is probably what it's doing. It's actually like, at this point we're thinking it improves mitochondrial respiration, so it somehow protects their health within the cell so that they don't get spit out as part of that inflammatory process. And I'm just kind of like summarizing it here, but I think we felt pretty confident about its anti-inflammatory effects beyond its traditional use, right? It definitely reduced damp expression. One interesting study we did on the Mito tracker. So we looked, is a study where you can essentially experimentally highlight the mitochondria, and like you can count like how many mitochondria, and like a leukocyte has about like 4 to 6, and TXA treated leukocytes in media would get like 8 or 9, like they'd make more. So it's biogenic, biogenesis of mitochondria, and they get kind of like fat, like healthy, like fat mitochondria, if that makes any sense. So we definitely had this connection between TXA and like improved cellular or mitochondrial bioenergetics and biogenesis, which we're like, like this definitely we need to go further down this. And then one other thing that was interesting and kind of segues on our research is that we studied it in burn wound conversion. I'll explain why. It's basically mostly because that's what the military wanted. So when there's something called the Military Burn Research Program, and so they have these focus areas, and you have to like hit their focus area, otherwise they don't really care. So you can't really, it's not like investigator initiated, I want to study this, like more NIH kind of style. So you have to just like hit that. And so we're like, well, it seems to like have some effect on mitochondria. And they wanted stuff on burn wound conversion. We're like, mitophagy, apoptosis, all those things are part of the process of burn wound conversion, if you believe in it. That's a little bit controversial. But so we were like, yeah, I think TXA will fix that or help that, right? And they bought our story. And so we just literally wrote it that way. So we did we did 2 models. This is actually a big grant, about $1 million. But we did 2 studies. So this is what they call a cone burn model. And you see right here, essentially you do 4 full thickness burns, and there's about 2 millimeter separation. And it's a well validated way to sort of modulate or to create or model burn wound conversion. And then you give them whatever drug or topical or injected, or a lot of things have been studied to sort of manage to affect burn wound conversion. So that was one model, but one thing that hadn't been done, this sort of classic cone burn model is like a single cone burn like that. We did that, but we also added a larger burn so we could see like what it did in the context of a larger injury, not just this small cone burn. So that was the more novel part of it. And this is kind of just like a representative example, but the TXC treated animals had a lot less. You only had like, a few little spots. And that was pretty representative across all the experimental groups. So it seemed to have this effect on even, and maybe this was, again, that mitochondrial effect. And it's just like close up on H&E. It seemed to retain a lot of its like structure. These are full thing, like, well, not in this way, but you didn't have like the sort of like extensive coagulative necrosis that you would see with just the untreated injury. And that was pretty consistent too. This is in the 30%. So with the bigger injury, like did the bigger injury affect this burn wound conversion? And we got pretty much the same results. It wasn't as robust, as the smaller model, which might make some sense because there's just a lot more inflammatory mediators around. And then this was interesting too, because we were trying to figure out, well, why? Like, how is it? This is looking at conversion or the sacrifice date, or when we would measure the conversion would be at 7 days. So they'd have the burn injury, and then 7 days later they would we would evaluate the tissue, and those ischemic zones. And we looked at this on for a couple of markers. There's something called Carthrick 1, which is actually like discovered at a research institute. They were studying other I think like fat inflammation. But anyhow, we used that marker because it was kind of in the lab, and they're like, hey, like see what's happening. It's kind of a marker of regeneration, which is different from proliferation, where you just have more cells, like more cells will be created, versus sort of a remodeling marker. So it shows that the cell is remodeling. And we showed that with TXA treatment, the cells were remodeling. It wasn't really, there was a trend. The KI67 looks at proliferation. We showed a trend. So maybe, it's kind of hard to say. We never really could get significance for that, but we did get significance pretty consistently for that sort of regenerative trophic effect. So we didn't see any in the early models. I don't have it here, but in the early models, we didn't see any really difference in apoptosis. So we think that TXA is somehow helping these cells kind of hang on, or not die, if you will, in that ischemic zone. And so it goes with that sort of trophic effect, effect that it had on the mitochondria in the previous studies. So, so we concluded that TXA likely improves tissue regeneration and wound healing. We had a similar effect in these studies. We looked at the cytokines. It had the same, the damp release. It had similar effects as our earlier studies on mice. These are rats. And then looking at just cytokines, traditional cytokines. But I thought what was actually interesting about this is it seemed to be differential in the different organs. So we had reductions, this is for rat hearts, we had reductions in IL-1 alpha and TNF alpha, but selectively. The other cytokines were, were all over the place. Some were really high, but it was like different there. And then looking at livers and kidneys, TNF alpha was suppressed, and IL-1 alpha in the kidney, but those are the only ones that were suppressed. So it was like very selective per organ, which was kind of interesting. And then we also showed similar reductions in immune cell infiltration and vessel leakage. This is the Evans Blue study. So basically see how much dye leakage you get. But pretty potent anti-inflammatory effects. Seems to have like a blocking of the endotheliopathy of trauma as well, or endotheliopathy. So then we started looking at TXA itself. So we're like, okay, like, how is it doing this? Because no, obviously nobody had looked at that before. So there's a process called DARTS. Don't ask me I can't remember what it stands for, but bottom line, you essentially see where the TXA binds. You kind of dissolve all the components with and without TXA, and you see where TXA stuck to. And what we saw was this pyruvate kinase had really high affinity. And this with TXA it had a very high affinity to the pyruvate kinase. It had some other stuff that was pretty high on that, but that one stood out and was reproducible. Because it can be a kind of finicky study. It doesn't always, you get a little bit different, but that was like persistently PKM2 was always. So pyruvate kinase has three, maybe a fifth, or sorry, four, maybe a fifth isoform. But the ones that are well known as liver, it has its own pyruvate kinase that's only found in liver cells. Red blood cells have their own, and then just about every other cell has M1s and M2s. We don't really know what M1 does, but M2 has some important effects I'll talk about here. And it's just to remind you, it's like sort of that last step before you get into the Krebs cycle. So there was a lot written when we looked through the literature. There's a lot written about PKM2, and it's particularly in its tetramer form. So it comes in a dimer, a monomer, dimer, and a tetramer. So like a four-headed monster, if you will. Has all these like clearly mitochondrial effects, right? And very, various parts of the literature generally. Wound healing, diabetic glomerulopathy, so on and so forth. So we're like, oh, like maybe this is actually like the target. So protective role was pretty well established in the literature, and proposed to tissue repair and angiogenesis. So it all made sense for us. And there's a drug experimentally, just given experimentally called TEP46 that just pushes PKM2 to the tetramer form. So you can study it just like by itself without TXA. So we did a few things. We actually looked at epsilon aminocaproic acid to see if like this was maybe just some sort of general like effect of antifibrinolytic drugs. And actually did see some like effect as far as pyruvate kinase expression, but it was just not as robust. But it was, we did see an effect there. So maybe this is something that even EACA can affect. This was kind of interesting. So we showed that TXA bound was had in the nucleus and the cytoskeleton, it was less bound there, and those are dimers. So when PKM2 forms a dimer, it goes into the nucleus and it initiates like an inflammatory process. But when it's in a tetramer form, which is preserved with this is on a Western blot here. It's when PKM2 is in the tetramer form, which TXA preserved. It just it was pretty consistent. It kept it in that form and reduced the dimer form or inflammatory form. So we showed, here's your Western blot here. We see the tetramer form with TXA, pretty, consistent expression of it. And then here, this was actually kind of interesting. This is in media on the bottom graph here. We took all the growth factors out of the media to see if TXA had a protective effect, and we showed that it did. It actually decreased cell apoptosis, essentially, on the DAB stain. So, less cells just, died with the lack of growth factors, right? So it was a protective in a starvation period zone, environment, I should say. Here we show its effect on phosphorylation of ER. These are inflammatory mediators and intracellular mediators. See, it had a differential effect on that, but it preserved it even in the it preserved the phosphorylation even when there was no growth factors. And then this is just another representation of that reproducible seahorse data where we were showing that the mitochondria had this increased biogenesis, and it was very consistent. So we looked at just PKM2 suppression just by itself, so just TEP46, no TXA. And what we found here was it was interesting too, at least acutely. This is, let me take that back. Let me back that up a little bit. We got another grant to look at, and this was a NIH COBRE pilot grant. It was looking actually at age, and we're looking at burn injury or burn wound conversion based on age, and whether like PKM2 could modulate that. But it had really no effect on, which was interesting. It had no effect on burn wound conversion, but it did have these acute effects. So the TEP46, had less vessel leakage, less inflammation when you gave it to the animals. This experimental drug that just keeps PKM2 in a tetramer form, and so it didn't have any effect on burn wound conversion. So what we think was happening here is that TXA keeps PKM2 in a tetramer. At least it's part of it. It explains part of it. It obviously doesn't tell the whole story because by itself didn't have any effect on its burn wound conversion. And then so that obviously has some driving mechanism to mitochondria that promotes oxidative phosphorylation, mitochondrial energetics, and biogenesis. Which so one criticism we had, or in some of the grant applications was, well, what if this is just a plasmid thing that that's mediating this whole thing? And so we did a knockout model. So with these, it's actually kind of hard to keep these guys alive too. The plasminogen knockouts, we actually knock out plasminogen. They live like 4 or 5 weeks, but they're pretty weak. But in a heterozygous or in wild type and a null, we expose them to LPS, which you expect to have inflammation or cytokine increases, and in both models, TXA worked. So it has to be independent. Whatever it's doing is independent from plasma. So that's kind of where we're at. So we know it has a really powerful effect on mitochondrial biogenesis and energetics. It definitely seems to have this pretty powerful effect on limiting the damp release, probably through this protection of the mitochondria, or at least mitochondrial damp release. And all these downstream effects are dampened. So a lot of promise in that, but we still don't know like how it works, right? So kind of like where we're going in the lab now and trying to get more money for is, to look at these in a very detailed way, look at all the mechanistic, where TXA binds and sort of really define the molecular pathway. It's kind of our next steps in it. And we also, just as a parallel, we also are looking at TXA because it had all these really strong effects on endotheliopathy. Like, could it be a resuscitation adjunct itself, right? And so we're, knock on wood, hoping that we have this, there's a DoD grant that we had, that actually scored high enough last year, but, they ran out of money or something. I don't know, yeah, the government's really interested. But anyhow, we're hoping that'll get funded this year. Or, I don't know, in the current environment, I'm not sure what's gonna happen, but, hopefully. So yeah, that's like kind of a parallel, project. And then, we wanted to look more at the wound healing properties of it, because it seemed to have this effect on, particularly in that burn conversion model, which is kind of interesting. And there's also a lot of stuff in the like dermatology literature, with like topical applications of it on various, you know, skin ailments. So it seems that there's definitely something there, and maybe it's all related to this effect. So yeah, again, we're trying to get that, more money to sort of study in a very detailed fashion, the mitochondrial effects. We got like at least ideas around some knockout models, and there's something called a BNIP3, which is this sort of a mitochondrial complex 1. It's an important factor in it. But you can knock it out and see if what TXA's effects are on the mitochondrial complex 1 and the calcium uniporter. I actually learned like a ton of like mitochondria stuff from this, that I knew nothing about before. So anyhow, that's kind of be the focus of sort of the cellular level, and then we also want to look at that tranexamic acid as an actual resuscitation adjunct. And the idea is to look at it in a pig model, with under resuscitation, kind of standard resuscitation, under resuscitation, 40% burn, see what TXA does to urine output, so on and so forth. So that's kind of what we're looking at. And it's just some newer data about TXA's effect directly on the mitochondrial complex 1. So it does have some internal sort of modulating effects beyond, just driving PKM, or just driving pyruvate into the system. So, there's some, this is the picture of the medical center. Oh, there's a helipad on there now, but it's just a little bit old. And that's downtown Portland. Beautiful place to live. That's the research institute that's in Scarborough. And so Igor Prodovsky is, me and him, and more recently Anyonia Gunter was like a mitochondrial biologist, researcher. And he actually has a model of where you can fluoresce the mitochondria different to see what, how much mitophagy is happening or not. So we're going to use that model in the future. But just shows you the importance of these collaborations. On a side note, one of my colleagues is looking at TXA in a TBI model, cortical impact, along the same lines. Because it has some effects on neuroinflammation too. So another collaboration, and then there's another lab that's looking at TXA in terms of like the euthyroid 6 syndrome. So just, and we're sort of like, cross-pollinating the entire, research institute. So it's cool to be a part of that. But you definitely can't do it out of a big team. And that's the funding so far. Hopefully more to come. See how it goes. Thanks. I don't know if I have to do it. I have a little time, right?
Perfect. We have questions.
I do, but we can take questions.
Got some, guys. All right. Yeah.
We're doing okay. Okay. So yeah, it's like kind of I was thinking for the resident, like what I would do differently. In this path, this path is kind of, it's more or less worked out. But there's definitely things I would have done differently. And things that that you should consider if you're like interested in stuff. So if you're contemplating basic and translational research, I know it's not for everybody. These are kind of things. it's definitely not for everybody, but they definitely need us in the sense that like by by them, I mean the PhD scientists, um, like they don't have the question. You know, they really and like they're great at like, you know, like helping you get the model to study it, you know, like the promyelocyte cell line, things like that. They have a tremendous like, you know, um, base of knowledge and like the various techniques and stuff. Um, but like they, you know, like we have the questions that actually really matter. And so um, we definitely need people that need learners because there's just a ton of stuff that we just don't know. I mean, even like look at just TXA, we don't know. We don't really know what it does, right? It may not even be the anti-fibrinolytic effect. It might just be this stuff, right? That has the survival benefit, no study, you know, crash studies and so on. So you definitely need to get trained in it. So and it's not really so much about um, you know, the specific you know, lab or what, you know, and obviously just look into something that you're interested, right? But it's being able to speak the same language and understand like, you know, what a, you know, speak the same language, what's PCR, what's a Western blot, Northern blot, so on and so forth. How, you know, what kind of information you can get from these various things. So you can, formulate really, cogent hypothesis and whatnot, and methods for it. And then you can like be in the meeting and actually know what's going on. I did a T32. I thought it was great, preparation for me. That's one thing I did right, I guess. You should definitely negotiate some money. I got lucky because I got the a double ST award, but definitely none of this would have got off the ground without that. It's about $50,000. But nobody really takes you like if you go like if you go to the research institute, you'd be like, hey, like hang out there, try to like get in on stuff. But if you don't come with money, they're like they don't really show much love. Uh, um, like I was saying before, collaboration is the key, especially as a surgeon. I don't think you can really do it in sort of modern RBU driven, you know, uh, setup. It's just, it's just, and like in my particular case, like, I'll come there for like the animal experiments for the most part, but I don't have to like really worry about any of the data analysis or like, cellular, the cell work or anything like that. So that's helpful. Somebody told me this, like institutions don't love you back, but people often do. So, um, those relationships that you build, like don't, they kind of sustain you through this. But, institutional leadership changes, the focus or, importance of things changes over time. Um, the best thing to do is to kind of like align yourself with the goals or principles of the institution, but that will change a lot. And so, even when they promise you something, like you may not get things change and you may not get it. Just like be aware of that. And then I think the name of the game is just leveraging that preliminary. So you need that little bit of money to get things started. So it's nice if it's part of like wherever your package, you get like 3 years of 50,000 or something like that to get going, get that preliminary data, and then you try to drive this into um, um, bigger grant funding opportunities. And also, I think this on the next one you got learn about the funding opportunities. There's there's industry stuff. There's sort of the NIH system, the different centers. Like there's a lot of different mechanisms. So like really, it's like spending some time and like learning that. There's a lot of opportunities for I don't know about in the next 4 years, but in general, there's a lot of opportunities. And you sort of get comfortable with failure because you will apply to a lot of these, and you think it's actually pretty good work, but we've been rejected plenty of times. I think it's very good work, obviously, but we you just have that's just like the name of the game. It's probably like I think 15% success rate, probably something like that, and that's pretty good, right, I think. So you got to get used to that. You know, I think you get your, like, as you, well, maybe this is a little bit for, like, you know, as you get further along, you kind of try to build up some sustainability. There's some NIH things like R35s. You know, there's like trying to get, you know, like research endowments. You know, sometimes there's like donation, like we got a big donation to the burn center from, you know, one of our patients that was, you know, treated, you know, I think a couple of decades ago, but we turned that into a way to just, you know, at least have some money for research, because you will go through these little funding gaps, if you will. And then, you know, I think mentorship and sponsorship, bringing up the next group, again, along the same line of, you know, promoting others, building teams. That's really how you get very successful, and you create a legacy, and it kind of bleeds into other people's, you know, research, like my partner's doing like TBI research based off of, you know, kind of our collaborations and whatnot. So, and it's a long-term endeavor, you know, like it takes a while, like this will take like a decade or more, like to get to the end of the, you know, if we ever get to the end of the road, but it's important stuff. It's important work. And I think that's all. Yeah.
We are actually unfortunately at time. And so if you have questions and you're here, please comment up afterward. And if you're online, if you want to send a message, we can forward it to Dr. Carter. Otherwise you could email dosadmin@uw.edu and we'll find a way to get it to Dr. Carter to answer. So apologies, just want to respect everyone's time because it's 7:30. So thank you again.